Russell Singleton joining us in studio this morning from Tripp Family Medicine. Russell is a physician assistant. As your email also says, we don't bring this up often enough, but it does help with your street cred. You're a faculty member at a very well known university.
I am, yeah. I teach a course in communicable and non-communicable disease at BYU Idaho.
I would say that that's a pretty big deal.
It's a lot of fun. I'll say that. It's an honor. It's a lot of fun. I get to do what I do, um, or take what I do in the clinic to the classroom. And I think that's great for everybody.
Today, we're not really talking just specifically a disease or an illness, although some people might consider it that. We're talking a little bit about government intervention in the medical system.
Yeah.
And you have a couple of things you wanted to mention about that today as well.
Yeah, this should be a lot of fun, potentially dangerous.
Yeah.
I realize we're gonna have to watch those phones pretty carefully, but we're gonna talk about the quote unquote failure of a government program called Meaningful Use that was designed to get hospitals, get physicians to utilize electronic medical records, and how it got part of the way there, but was recently officially and suddenly shelved because of a couple of reasons we'll talk about today.
Want to point out, if you'd like to reach the physician assistant while he's in the studio with us today, 7360300. It's also 26. It's 8:35. You're listening to Top Story as well on News Radio 1310 KLIX and newsradio1310.com with Bill Colley. We do Better Health every week between 8:30 and 9 o'clock. And for a lot of people out there, if some people you know darn well, they don't see a doctor or a PA very often. They're probably even wondering, what was this all about?
Absolutely, this goes all the way back to 2009 when, as part of a larger bill, Congress passed something called the High Tech Law, and I think it was well intentioned, and a lot of government programs are well intentioned, and they all have consequences, good and bad. But the idea was to help healthcare practitioners use electronic health records meaningfully, and that's where we get the term meaningful use. Now, the way they decided to do that was to provide financial incentives in terms of I guess just blanket payments, and then the ability to avoid reductions in payments, and we're talking about Medicaid and Medicare. So it amounted to, somewhere in the field of 50, $60,000 over 5 years. Program was designed to run through 2017, and the goal was to increase quality, increase safety, improve coordination of care, engage patients and families, and then ensure privacy. So everything sounds good, right? Those are all goals that we all share, and I think I think anyone would agree that electronic medical records are probably the future, and we can talk about that. But it had a lot of unintended consequences, and that's really what I wanted to get in today. First of all, there was a lot of debate about whether or not electronic medical records were even ready to be adopted. The VA on one side was doing a study, and they said that they were seeing efficiency improve by about 6%. The American College of Physicians, on the other hand, was saying that administrative time went up on part of the physician by about an hour a day. So that's 1 hour less each day that your doctor is able to see you or help you because he's filling out forms and he's clicking buttons. Um, and speaking of that, when was the last time you went into your doctor and actually got to look at him? He's got a computer in front of him now, and usually it's between you and him. And instead of looking at you, he's looking at the computer and he's clicking buttons. He's oftentimes reading off the screen because he's got certain things he has to fill out. But as we've moved forward through the years, I think some good things have happened. I think there's been some good things that have come. EMRs have improved care in some ways, but ultimately the program was deemed a failure. And just a couple of weeks ago, one of the spokesmen for the Centers for Medicare and Medicaid said that the program was going away because physicians, as we phased through this three-part program, physicians were not only falling behind, but they were giving up. They were finding that it was much too onerous and it was way too expensive to keep up with this, and patients weren't necessarily doing better.
We've got to take a break in about 40 seconds, but I read a piece, I think, in a newspaper on Monday or Tuesday that said last year was the first time in American history that government health payments exceeded Social Security payments. And I would wonder if a program like this helped. We got about 20 seconds here before the break, but was it an instigator or did it play a part in that?
Wow, I don't know. I think the government is always, and any payer is always looking for ways to cut costs. But after the break, we'll talk about some of the expenses on the part of the physician, and I don't know if it really did anything to control costs. It's a great point.
In other words, it's one of those nebulous type of things we may never have an answer to.
Exactly.
We got more with Russell Singleton on the way from Tripp Family Medicine in just a couple of minutes. It's 25, 840. Bill Colley with you as well here on News Radio 1310, KLIX and newsradio1310.com. Our studio guest is joining us from Tripp Family Medicine right here in Twin Falls. That is physician assistant Russell Singleton, and joins us on Wednesday mornings in the rotation. Sometimes it's the doctor. In fact, we're going to divide this up now on a regular basis, aren't we? It's not going to be like a random rotation any longer.
Well, because we have some new providers in the office, Jeremy Daly, PA, and Crystal King, NP, I think people are going to start to get to know each one of us a little bit better. We're going to spread the love.
That's a great idea. And of course, people coming in through the door will notice some of these changes as well because the bigger staff means you can see a lot more people.
Absolutely. Dr. Tripp and I, for the last several years, have been the only ones there, and we've gone from maybe 5, 6, 7 patients a day to almost 20 patients a day, and we felt the need to expand in order to keep that availability open. We didn't want to become just another clinic where you could see your doctor in 2 or 3 weeks, or you had an emergency, couldn't get in, and you end up going to the ER, which, if we're going to talk about cost, which factors into our conversation today, that's one of the worst ways to get health care is to go to the ER with something that could have been taken care of by your regular doctor.
You want to grab the headset for a minute? I think we have a telephone caller. We are talking about some of those medical costs and government programs and the like. And we have a caller with us, and you're on the air with our guest. Good morning.
Good morning. Thank you, guys. I'd like to make a contribution after two quick questions. First of all, I'm getting older and I feel like the energy is leaving my body. What do you recommend for maybe an energy drink? And also, my body's all worn out. What do you recommend for pain pills? And when I lived at South Lake Tahoe, I helped build the most modern sewer plant in the world. And at the last stage of the process, the water was just kind of slightly gray. There was a screen in the shape of a hot water tank, and inside were these little things jumping up and down and looked like Mexican jumping beans. I said, "What the hell are those?" And they said, "They're vitamin pills." People would spend money on vitamin pills that go through their body and wouldn't be absorbed. So the best thing to do is to bite the vitamin pill when you eat it.
That's a great comment about those vitamin pills. That actually is true. A lot of the vitamin pills we take have the water soluble vitamins, like all your B vitamins, for example, are water soluble, which means what the body doesn't need, you pee out. And if you're eating a well balanced diet, you probably don't need any vitamins anyways. And so I would take that a step further and just say, make sure you're eating well. But to answer your first couple of questions, um, I think we got to get you in and talk to you because I think there is some degree of fatigue and weakness that comes with age. But if this is a sudden change, if this is a debilitating change, we gotta talk. We gotta talk about sleep. We gotta talk about hormone levels. You might have a chronic condition that is poorly controlled. Um, I see a lot of people with moving on to that second question with generalized joints and or joint pains and muscle pains. Sometimes it's good old fashioned arthritis, and we can talk about anti-inflammatory medicines. We can talk about joint injections, joint replacement. But sometimes it's a little bit more nefarious than that. I diagnosed a patient with rheumatoid arthritis, which is a very different, very unique, progressive, debilitating form of arthritis, and she was probably early 50s, right about that time you'd expect the wear and tear to kick in, but because we got her in, because we talked to her, did some lab work, her her treatment is going to be much different, and I hope her outcomes are going to be much different too. So it's hard to give a blanket type statement, but it's something I'd recommend we get you in for sure.
He doesn't sound like he's got a lack of energy. I think that's the one thing I really appreciate about some of the callers is they, when they're on the line, they seem to have a great deal of it. We want to put out Russell Singleton in studio with us until 9 o'clock this morning, and we're up at 8:48 right now in 23, and he's here from Tripp Family Medicine. You had been talking a little bit about this government program going away, and we wanted to pick up a little bit of that too as well.
Yeah, it was designed to implement or to help implement electronic medical records, which I think in general are a good thing, and they're not going away, but they're certainly not perfect. We talked about how one study by the American College of Physicians indicated that healthcare providers were spending an additional 48 minutes, almost an hour a day, just on the technical aspect of it. Now that's two, three, maybe four patients that we could have seen during that hour. But EMRs have privacy issues. I was reading another study recently that quoted back in 2011 there were 380 distinct privacy breaches affecting over 18 million people. Because now you just don't have a, a paper copy sitting in a locked file cabinet in your physician's locked office. You've got your information either on the cloud or you've got it on some type of local server, and that exposes it theoretically to anyone with internet access. And we've seen it happen. We see it happen every year. Another issue with EMRs in general, and it was an issue that kind of made these government regulations difficult, if not possible, to follow, is that it's incredibly expensive. You want to take a guess about how much it costs per physician to get started on an EMR? It's about $50,000, and then ongoing per year, you're looking at about $8,500, and that's per physician. So at Tripp Family Medicine, we've got 4 providers. You can start to imagine how those costs really add up, how the overhead can be enormous. I don't think people realize how expensive it is to run a medical office. They see the cost, they see the bills they get, and they assume that their doctor or PA is kind of pocketing all of that, but margins can be pretty thin. And then when you get the government or insurance companies demanding that you do things a certain way, costs go up. Eh, Speaking of cost, Dr. Tripp and I were having a conversation the other day preparing for this show, and we kind of got off on the topic of cost and how some patients would really like us to have a menu on the board or on the door that says this is what you're going to pay when you come in. This is what a blood test costs. This is what a physical exam costs, and we would love to do that. We really would. But the reality is, we don't set the cost. I don't think people realize that. We contract with the insurance company, and they tell us how much they're going to pay us for X, Y, and Z. The patient then contracts with the insurance company, and they agree to pay their premiums, and the insurance company agrees to to distribute however much was agreed upon. But oftentimes, I don't know what it costs, what we're doing. And when you start getting government regulations in there and you start creating hoops and you start creating requirements, there are a lot of unforeseen costs that start to add up. And eventually, in terms of this meaningful use law, physicians gave up. It was onerous, and that's when they finally came out and said, "Okay, it was well intended, but obviously it's impossible to comply, and we're getting a lot of kickback. So it's done. We're gonna develop something better. Of course, they're not just gonna leave it alone."
We want to point out too that that's a good thing though that now and then the government actually says we made a mistake and we're going to change it. People are probably surprised to hear that. We have a caller with us, Russell. Russell Singleton joining us in studio from Tripp Family Medicine. It's 8:52 and 23, and you're up next on Better Health on Top Story as well.
Russell, I'm not sure if you really want to get into it or not, but have your reimbursements changed dramatically this year? Because I know with durable medical equipment, it has by the end of this year, it will be 40% a 40% cut in what they reimburse for durable medical equipment in 1 year. And I'm just curious if that's happened with the care side of it too.
That's a great question, and that's what I'm happy to address. Admittedly, I don't know a lot about the billing side of things. Like I just said, oftentimes I don't even know what the cost of the services we're providing. I focus on the medicine, and I let the billing people focus on that. But in general, we are threatened with decreased reimbursement all the time, all the time. In fact, poor Dr. Tripp has been out of the clinic working on another government program called PQRS, which again has to do with quality measurements and reporting back to Medicare. And they are now saying, if you can't provide us this data and meet certain requirements, we're going to cut your Medicare payments by, I think it was 2% this year. And the next year it'll go up maybe 3 or 4%, something like that. So instead of our chief medical officer seeing patients like he was designed to do, like he wants to do, he's tucked away in an office on a computer on the phone with the EMR trying to figure out how in the heck we can get this reported so we don't get docked. And that's just ridiculous.
How is it, when we think about these regulations, how is it we expect in the future that there's a movie out about 30 years ago called Brazil that detailed how in the future world with all the bureaucracy and regulations and the paperwork, nothing would get done and the whole system would clog up. Uh, there is a concern, I'm sure, that that's going to happen. And at some point, people just aren't going to get the care that they need.
Yeah, I hate to say it, and I don't want to wax political, but we we have a very dysfunctional healthcare system. I think we have some of the best doctors, some of the best nurses. I think we have some of the best technology, but the way we pay for things is just ridiculous. There's no other industry out there where you provide a service without knowing how much you're going to be paid for that service, and then it's sometimes 6 months to a year before you're actually paid for that. The patients don't know. We don't know. How we're expected to thrive in that situation. I don't know. It's not going to last much longer. Something's going to happen, and and we're going to have to go back to the drawing board.
Maybe, was it Dr. Ron Paul once said, I watched a 7-minute video he put together. He'd like to go back to the days of the old indemnity insurance plans, I think, 1971 or 72, when HMOs first started to come in. And he said he thought he said he thought it was a system that worked well and people could negotiate when it came to prices or could pay in installments, whatever the plan didn't cover. Do you think there's any merit to that?
That's a great question. I think it's time to start looking at alternative ways of payment. At Tripp Valley Medicine, we really believe in your health, your way. We believe in you, the patient, making the decisions. We don't want government telling us how to do things. We don't want the insurance company saying which medications I can and can't prescribe you. But that's the world we live in. I would like to find a way to make healthcare more affordable. How come we can't treat it like car insurance, where you've got liability insurance in case you hit someone or someone destroys your expensive new vehicle, but you don't bill your insurance for an oil change. You don't bill your insurance to rotate your tires or to replace the alternator. It's a couple $100 here and there. Hopefully you set money aside and you pay out of pocket. I think we've got to find a way to make healthcare affordable to where people pay out of pocket. They can use market principles to shop, find the best provider at the best cost, and they carry maybe a catastrophic insurance, because some people will get in a car accident, they will get cancer, they will have to be in the hospital, premature babies will be born, and those those bills also need to be uh, reduced somehow. And there are certainly ways to do that, but we shouldn't be relying on insurance companies, on third parties to pay for everything, because then we turn the decision making over to them too. And that's the kind of the crux of the conversation. We need to find a way to get away from that. We need to find a way to return the decision making to you and your doctor. And at least at Tripp Family Medicine, we're doing everything we can to make sure that as few as people as possible outside that exam room are controlling your care.
Very quickly before we wrap up, Russell, today, for people who would like to get in touch with the office, multiple ways to do that.
Yeah, 933-4400. You can speak to our lovely front office receptionist, Heather, and set an appointment to see one of us. We could probably even see you the same day.
I was going to say, same day service, rare in medicine. It's nice to hear that.
Please call. We'll prove it. We'll put our money where our mouth is.
Russell Singleton joining us this morning from Tripp Family Medicine. A better health with Tripp Family Medicine. They're located right here in Twin Falls on Fillmore Street, directly across from the main post office. 9 o'clock news coming up in just a moment from Fox. And one more hour of the program, Top Story with Bill Colley ahead.